Hello, my name's Jan Clarkson, and it is a pleasure to be here at this very significant and exciting conference. I'm here to speak about getting evidence into practice. And the question might be, what evidence? And actually, does evidence have an impact? And should we have an international vision? Your conference is titled Evidence Matters. And so I'm going to share with you some of the experience we've had in Scotland. And Deborah in particular asked me to talk about SDSEP, the guidance development. Triads, our understanding of getting evidence into practice, and also fiction, the UK national trial on how to manage caries in young children. So, first of all, things have changed dramatically in terms of what people believe and understand the process of diseases and also our management of it. However, still in the 21st century, if a quarter of you go to the hospital, you would not receive treatment for which there is evidence of benefit. And in fact, up to a third of you would receive treatment for which we know there is harm or there's no evidence of benefit at all. So the question is, why is that happening? Now, my journey started in this place. This is a Lancashire mill town called Bacup. And it's called Bacup because it was in a valley, and when it was forested, they used to hunt the deer, and they would kill the deer after backing them up the valley to this small inlet. And so that's why it's called Bacup. And this picture here, what you might be able to see is a window there on your far left corner, and that was the dental practice that I attended as a child. And it was so long ago that if you were a good patient, you would actually get a sweet as a reward. And things have changed so much in the space of time, and this is in the 1970s when I was a young child. But also what happens in Bacup at Easter, and it's Easter, and that's why I'm not with you at this conference. I'm away with my family in Cornwall, but these are the coconutters. And the coconutters are the Morris dancers at Bacup. And every Easter, they come out and they parade and dance around the streets. And they do the same dance with exactly the same music, led by a brass band that they have done for tens of years. And the question is actually dental practice like that. Once people graduate, is it that things are just done the same way that they learnt at university? So, I'm going to share with you the experience of coming to Scotland 20 years ago now with a remit to get evidence into practice and to lead the production of guidance for dentistry. And SDSEP, the Scottish Dental Clinical Effectiveness Programme, is the arm of the NHS Education for Scotland on which this is based. So 20 years ago, and coming to Scotland, I was told I was coming to the most exciting place for research because there was so much disease. And actually, at that time, half of the 15-year-olds of Scotland would have holes in their first permanent molars. Now this was at the turn of the century, and already Cochrane had established that fissure sealants will prevent up to 70% of the decay. But actually, Scottish dentists, only 25% of the children had these plastic coatings. It was a time of capitation. And so, when people asked what would change the behaviour of dentists, even though guidelines were published and the evidence was clear, the answer was money. Now, I don't know whether that would apply in Australia, but that was the motivation in Scotland. And so we actually did the first randomized controlled trial of paying dentists as opposed to education. And then actually education and a fee, would that make a difference? What we knew was there were 25% of children at this time who got a fissure sealant. In Scotland, we have around 900 dental practices. We randomly sampled a third, around 300. 58 were ineligible, which meant they were an orthodontist or they were dead. And around half of the remaining ones agreed to take part. After 3 years, what you can see is that in the control group, as predicted, 25% of children had a fissure sealant. Paying the equivalent of a fee for having a filling, it increased to 35%. And this was my first lesson. Do not guess that you understand human behaviour or what will make a change. So these results were published, and in 2006 they actually changed policy and a new fee was introduced for fissure sealants. And we thought, job done. Absolutely incredible. Fissure sealants were reinforced in the SD set guidance that was published in 2010. And then there was a national survey in 2013. And what this is showing is this salmon colour here. This is the percent of 11-year-olds who have fissure sealants on their first permanent molars. And what you can see, it's around 30%-ish. So representing the evidence of a 10% shift around that. And it changes. The most deprived at 26.9%, the least deprived at 26.2%. So there is a little variation, and that was 2013. So that is many years after establishing the evidence and changing policy. What's perhaps more shocking are the results from 2017. And what you can see here, rather than by deprivation, this is by area of Scotland. Again, it's the salmon pink, the percent of children who are aged 11 with fissure sealants. And really, it's sort of not changed, but you have got areas. And S, this is Shetland. So this is one of the Northern Isles. 64% of children. And I think that is because of the organisation of care. And it is about the issues that you're discussing at this conference around a managed clinical network and a model of care. What is quite shocking though is 16% in Tayside, and that actually is the area of Scotland that I work. But hopefully what this conveys to you is it's not so much the evidence, it is about getting evidence into practice. Now SDSEP was set up, and what we knew at the time of establishing this program was that it was unlikely that there would be widespread implementation, and also that there would be many different attitudes and approaches to implementation. And often those are little understood, modest change, and I don't know, sometimes very expensive. And it's how do you make decisions around delivery of care? Now an expression that someone, Martin Eccles, came up with is often policies or principles are developed using ISLIADAPT. Now I'm not sure that you will have heard of ISLIADAPT, but you will all understand what it means because it's C seemed like a good idea at the time. And I know that you are at the point of devising a new system, a model of care for the children in Victoria. And my plea is, do it in a way that you can understand whether aspects have worked or not. And so Triads is the program of research that helps us understand why implementation of guidance works in some cases and not others. And this now has been published, and it is a protocol that has been used for around 10 years. It's embedded knowledge translation research within service, so we work, because we're based within Education for Scotland, we're able to embed tests of change within the normal service structure. It's multidisciplinary. We have an international advisory group that includes sociologists, psychologists, behavioural scientists, economics, statistics, and often dentistry is the least evident there. And we have devised a standardised process. Now this process starts for any guidance topic that SDSET takes on. And first of all, it's in the scoping phase. And the Triads researchers will interview patients and also health professionals to understand what the real needs of this guidance are. We then define professional behaviour outcomes. So for example, in children's care, it would be the placement of fissure sealants. We then do a diagnostic analysis, and it looks there at the determinants of that behaviour and also what would be the barriers of facilitators to change. This is all happening during the development of the guideline. And at this point, the guideline is published. And post-publication, we then determine whether there is subsequent knowledge translation strategies required. So we look for evidence that the guidance has actually changed the key behaviours to improve health. And if we decide that there should be an evaluation, it is done in the most robust way that we can, so that we can truly understand why something has worked. So this is a matrix to demonstrate that this is how we've applied this principle and methodology to the guidance that has been developed. You'll notice here, these are the first topics, and so Triads came along after the start of SDSET, so the scoping had already started on those projects. And so as you can see, that's just a matter of time really reflected in this matrix. So what I cannot overemphasize is the importance of Triads for the development of the guidance. And it has improved the scoping. It has also evidence about implementation concerns. It has now developed guidance with a more behavioural focused language that is more implementable. But really, a significant contribution is that this guidance now is the only dental guidance in the world that has the kite mark or accreditation of NICE. So our methods are the replica and as the standard of NICE guidance, which does have international recognition. So I mentioned it seemed like a good idea at the time, and people just come up with some ideas and strategies that are just unreasonable. So how we approach understanding behaviour is we follow the work of Susan Meeke, and what she has devised is a system called COMBI. And really what this is saying is that in order to affect behaviour change, or any behaviour, there are three things that are required. And these are the three principles that are used in a court of law and for the charge of murder. You need capability. That's psychological and physiological. motivation, maybe internal or it could be external, and you need the opportunity. And that is exactly what is required for practitioners to change, or indeed patients. So the theory that we use here, you can see, is the combi. And in order to understand the barriers and facilitators, what's called a theoretical domains framework is used. And that is really signalling or pointing to the important issues. It could be environment over here, or it could be knowledge, which is a psychological capability. These domains translate then into intervention functions. So an example might be education. It could be persuasion. And the outer circle depicts the policy categories. And as you can see, you have guidelines or even fiscal measures that might be applied. But these are applied knowing that there is a chance that they would be effective. So an example in dentistry, antibiotics is a huge issue, and I imagine it is in Australia too. Dentists in the UK prescribe around 10% of all antibiotics. We produced guidance to encourage appropriate use of antibiotics, because there's clear evidence that maybe up to 50% of those are not appropriate within the dental setting. We changed prescribing for prophylaxis of to prevent endocarditis, and this was around in 2008. And we coincided our work with NICE, and what you can see here is a dramatic fall, about 70%, and that is phenomenal. Rarely will you get such a change in behaviour. But that's one example. But we realised that from audits, criterion audits, the dentist, there was still shift possible within the total antibiotics. And so we devised and embedded a trial within service. And this is an audit and feedback. And so this is like a laboratory. And I think in Melbourne, with the work of Jeremy Grimshaw, there is a meta lab for audit and feedback. But we randomised the 795 dental practices, some into the control group, others into the intervention group. And some just got audit and feedback, which was their prescribing pattern at different times and with or without a comparator, which was the health board norm. Others got the same information, but with a behavioural change intervention. And that is a persuasive message, because we realised that was one of the factors that might affect change in behaviour. So, if I were to ask you whether or not sending a piece of paper out like this with the graph of the individual practice prescribing, the red line is the comparator health board, and this is the persuasive message, would it make a difference? Well, even we were surprised with the result. Nationally, there was a 6% fall in antibiotic prescribing. And we could attribute that to different interventions. For the dentist prescribing most antibiotics, there was a 12% fall in their prescribing. And it was a behavioural change message, and also the comparator that made the difference, not the frequency of giving that message. And so these were important points. And the 6% decrease represented over 20,000 fewer prescriptions. It has informed debates about antimicrobial resistance across dentistry and medicine. What's really interesting though, in Scotland, they've adopted this in medicine, not in dentistry. And so their priorities are within medicine. And so now we're coming up with other interventions, and we will be sending practice teams in to give audit and feedback. But again, this work is published and cited as one of the best examples of embedding research within service development. So, fiction. Now, fiction is a piece of work that I think it took probably 12 years from the call for the research to its completion. And what is scary is the answer to the question is 17 years, and that currently is the time that it takes from getting evidence actually into practice. So, fiction, filling children's teeth, indicated or not. The funder was the NHS, and this is a disclaimer, and there was a huge number of people. I am probably around 150 people, and that is just the academics and support. It included 70 dental practices across the UK, and they recruited over 1,000 of their child patients who were aged between 3 and 7. Now, this work has not been published as yet, but it hopefully soon will be. And given the time, it's just a few summary slides. So the question was whether for a decayed primary tooth, conventional approach, which was local anaesthetic, total caries removal, is any different to a biological approach, no local anaesthetic, sealing the decay in, or prevention alone. And it's prevention to arrest and manage the decay. All of the children got prevention, so the focus is around the management of the caries. And the primary outcome is pain and or sepsis. There were many challenges along the road, which we overcame, and one of them was motivating the children. They loved being in part, taking part. We had drawing competitions, and actually getting the final visit medal was a real treat. But the primary outcome was said to be pain and or sepsis, and also the number of episodes. So, after 3 years, conventional was 42% of children experienced pain and or sepsis. Biological, it was 40. And in prevention alone, 45. And I have to say, we were surprised. And what's got to be borne in mind is that this is not at the tooth level. So a child had to have a carious tooth to enter the trial, but this is about the child as a whole. And if you look at pain and sepsis separately, sepsis is the most sort of like reliable outcomes. This was visible sepsis. And as you can see, around a quarter of the children experienced that. There were no differences for quality of life measures or anxiety. And the cost effectiveness analysis I haven't shown because of the relevance. I'm not sure how that translates into your setting. So the conclusion of fiction was there was no evidence of an overall difference, no evidence in a difference in quality of life or anxiety. And the 3 strategies were acceptable, and the qualitative work led by Zoe Marshman clearly identified that. Children didn't like local, they didn't like having teeth out, yet they would accept it. And one of the big things coming out is the trust that patients and children and parents place in the dentist to actually know what is best for the child. The biological arm, I'm sure you may have heard of the whole technique. Now, some of the children were treated with that, and if you remember in the genesis of this, that this was over a decade ago. So not all of the teeth were restored with the whole technique. There were concerns more from the dental professionals around stigma and the appearance of the teeth. But actually, certainly in Dundee, it is seen as a quality standard. The because it's just like the rappers on the TV. And so in terms though of as a prevention alone, there were concerns from both the professionals and parents whether actually things should be being done as opposed to just observing and applying prevention. So whilst the preventive strategy was the cheapest, it wasn't the most effective. And there has got to be a decision made at policy level of what is the value of saving or avoiding pain and or sepsis. And I suppose it emphasises absolutely children had to have decay to enter into this study. So the best thing is to prevent it ever happening at all. And that is where the SD-STEP guidance comes in. And what this is trying to do is to support dental teams and is to maintain health, deliver preventive care, and, when needed, effective management of caries. What's important is to demonstrate the collaboration that's gone into this. Not only do we have all of the Royal Colleges, but all of the health departments. We've got the British Society of Paediatric Dentistry, Child Smile, which I know some of you will have heard of, and is NICE accredited. The overarching principles are these: to prevent disease, to reduce the risk of a child experiencing pain or infection or acquiring treatment-induced dental anxiety that might occur, and for the child to grow up feeling positive about their oral health and with the skills and motivation to maintain it. Maybe some of you have had a look at this guidance. There is an overview, and it demonstrates how, from assessing the child to a recall interval that is appropriate according to risk, can be set. And what we're often asked for are these flow diagrams, so that immediate visual of what to do. And this is the example of the flowchart or pathway for pain or infection and the management of the child presenting with that condition. We also have guidance on the categorization of lesions in order to determine then what is the most effective, or what are the options people have for the management. And this is where fiction will be informing the next reiteration of the guidance. So anybody can access our guidance here at www.sdstep.org.uk. There's guidance in brief and there's guidance in full. When I spoke to Deborah on the phone, we are very happy for you to use whatever you might like of the work that is done here. Absolutely, to avoid duplication is essential. And just a heads up, hopefully in the next few weeks, we will be launching apps, which you, I think, as internationals, will be able to access. And one of the 4 topics is child caries. The others are meronge, perio, and anticoagulants. And they will all have a similar layout, describing what's there, the recommendations, and then the advice that is given. But the vision, we have to start working differently for evidence to matter. And fiction is an example of producing evidence. And we have other trials that are ongoing in the UK. There's no point waiting 17 years for that to get into practice. So we have to work with the synthesizers. And Cochrane, as you know, has got sort of like gold standards around the synthesis of evidence and production of reviews. But no matter how involved I am with that, I do know they are not there to change professional behaviour. 300 pages is not what you need. What is needed is the guidance. And as groups, SDSET is a significant player in this international field, and it would be fantastic to have you join this collaboration that now includes the American Academy of Pediatric Dentistry as well. And we're working with the ADA, FDI and WHO. But there's no point in producing this guidance unless we understand and evidence its adoption. We have to implement and evaluate, and that is where Triads comes in. And embedding the research within the system that you are now in the process of developing is such an exciting opportunity. And I do hope in the future that I can come down under and see exactly what you're doing. Thank you very much.